Thank you very much, Professor McGuigan. Good evening, everybody. It's a great pleasure for the School of Pharmacy to be involved this evening in this closing MiniMed series for 2014. What we've done is we've put together a program in which I hope at the end of this evening that you will have a greater sense of who a pharmacist is, that you will be more assured in getting professional services from pharmacy, that those of you who are participating in the brown bag event will have greater knowledge of your medicines and will know more about their side effects and also about continuing to be compliant with those medicines, and that you also will have a sense, because I think it's very topical, the issues around generic medicines. We know that they present a proposition of better value to you. Do they present the same quality, safety and efficacy? And also to take some time to consider internet pharmacy. There's been a lot of organisation in this event this evening, and all those people are together at this point in time. And I want to really thank Michelle Flood, who has spent an enormous amount of time in putting the logistics of this all together. Want to thank the 12 pharmacists who are joining us both from within the School of Pharmacy and outside the School of Pharmacy to participate in the Brown Bag Usage Review. And I also want to thank our fourth year senior cycle students who are with us this evening and who are going to be able to direct you at the end of this lecture. They will have badges on with their names and they will direct you to the examination hall for those of you who have registered for the medication usage review. We're starting with this title, Potions, Lotions and Health Promotion, What Can My Pharmacist Do For Me? Not quite sure where I got that title. I think I was trying to be as cool as Professor Zena Moore, for those of you who are here who had a memorable lecture and a memorable title, Wound Management, Honey, Maggots and Other Medical Marvels, and I was trying to get there. What I really want to do, and the point beyond this, is I really want you to have an increased knowledge about pharmacy. And to that end, I've decided to tell the story in 4 parts. 1, where pharmacy comes from, so that part's entitled From Apothecary to Pharmacist. 2, want to think about, from your perspective, who is a pharmacist? What does it mean to be a regulated healthcare professional? What is their education? What is their skill set? What is their competence that you can expect from your family pharmacist? I then want to move, which I think is the key part of what I want to talk about, which is pharmacist as caregiver. And in that, I want to really think about medicines, think about the benefits of medicines, and also think about the risks of medicines, and how is it that you can reduce those risks by using your pharmacist. And in the end, I just want to take a shot into the dark, which is a little bit difficult at the moment because, as you know, we're all moving into a unified health insurance system. A white paper is due. We only have a strategic framework from the Department of Health at present. So what does that look like for you as people who are going to be in that healthcare system, and how might pharmacy fit into that? So that's the journey that I'm going on. The story starts when I myself qualified as a pharmacist, and as Kevin said, and as some of you in the audience may remember, Hayes Cunningham Robinson, who were really actually probably the first chain of pharmacies in Ireland. They had that flagship store, which is now Boots, on Grafton Street. I worked in Henry Street, and I set up a store in the ILAC Centre. And after that, and walking around city centre, I came across an empty retail unit, which I thought would be an ideal place for me to open my own pharmacy. And I went to a then firm of architects called Douglas Wallace Opperman, who were in Temple Bar. Met an architect called Roisin Murphy, and Roisin said that she would do a sketch of what my pharmacy might look like. And that's really interesting to me because that told me as an architect what was it that she imagined the role of a pharmacy was, and how is that going to be reflected in her design. So the design, the sketch perspective that Roisin did for the pharmacy, you see here. A very aesthetic space, interesting in the current issue of The Lancet, Hilary Moss and Des O'Neill from the Adelaide and Mead Hospital actually talk a lot about the importance of aesthetic buildings for healthcare delivery and the impact that has on patients. So that's somewhat of a coincidence, but it's a very aesthetic space. To the foreground of the space, as you look at it, you can see there's a conical flask. For those of you who watch Breaking Bad, you'll remember the flask episode where he gives instructions on how to, as an organic synthetic chemist, what are the various types of flasks. So that kind of looks something like that. So there's an idea that there's manufacture of drugs going on. There's a mortar and pestle, which is kind of a universal symbol of pharmacy, but again, it's about crushing and it's about manufacture. To the left, up high and down low, are distillation flasks. Maybe what's slightly different here is that there's an idea of extracting drugs from plants. Seems to be a comfortable chair. Then you're kind of led to what appears a little bit like an inner sanctum, and it's separated curiously by a half curtain. So this isn't exactly a transparent space. There's a distance between the pharmacist and the public. This is kind of where esoteric knowledge and mystical skills all get practiced. And then up at the back, sort of quite of a designer sink and a wet lab area. So that's Roisin's concept. What you don't see is that actually she also wanted to paint each wall a different color, which she did. And she also wanted to paint the outside lavender because she thought lavender was the color of healing, and she had recently had a burn and she'd used lavender oil and she thought it was kind of miraculous. And actually I didn't object to too much of that. So it was a very curious pharmacy. And in fact, the Sunday Business Post, when they were talking about Temple Bar in a subsequent issue, talked about, and for God's sake, even the pharmacy in Temple Bar is painted pink. Which wasn't actually, it was lavender, but there was no point in making the point. So there's a collection of ideas of what Roisin thought went on in a pharmacy. And in a sense, if you think about the journey and the role change of pharmacy in the 20th century, a lot of that makes sense. It starts really with the pharmacist taking over the social role of the apothecary. And the apothecary was really the person who made and manufactured drugs for patients and for doctors, and who supplied them directly to patients, and who also was a diagnostician directly with patients. So that real sense of manufacture that Roisin had coming from those days of apothecary. Through in Ireland to the transitional phase, and I think for us in Ireland the transitional phase is really heralded by the 1970 Health Act, which in 1972 gave us the General Medical Service Scheme. That really transformed the delivery and availability of medicines for the public in Ireland. Up to then, curiously, the availability of medicines was really through local authorities and through dispensaries and doctors who practiced in dispensaries that were owned by local authorities, which was a very unsatisfactory system for the public in having access to medicines. 1972 changes that completely. There's a General Medical Service Scheme. There's a lot of medicines available for the first time to the Irish public. The Irish state has really come of age in terms of healthcare delivery. And that really transforms pharmacy, because suddenly the amount of medicines that are being used by the public is enormous. Doctors' roles change. They become really prescribers of medicines, and pharmacists become dispensers of medicines. They're no longer manufacturing them. They're big-scale manufacturers who are making those medicines, and so the role of the pharmacist changes. To the current stage, where the pharmacist role has again changed to that of caregiver, patient care. And what has affected that change? What has affected that change is that medicines, as we know, have really transformed and changed the Irish healthcare system. But they've also brought with them risks, and managing those risks and managing the side effects and encouraging adherence has become a very big priority, and the pharmacist is the right person to do that with their expertise. And so pharmacies now have consultation rooms. They're engaged, as some of you will this evening, in medication usage reviews, where you bring your medicines, your supplements, whatever else you're taking, and you discuss those with your pharmacist. So that's the journey from apothecary through to patient care. And maybe there's something a bit disconcerting about that. Changing roles can sometimes, I think, be a bit disconcerting, but there is a unified theme through all of those role change, and that unified theme is medicines. In one of the papers that I read in preparation for this lecture, it uses a very nice phrase that the social object of a pharmacist's activities has always been medicine. So whether it's from manufacture, whether it's through to dispensing, whether it's through to patient care, medicine is unifying that. And now as we look at drugs from beginning to end, from drug discovery to clinical trials, to drug manufacture, really important for us in Ireland, to quality assurance of drugs, those that are released from manufacturers to the general public, to dispensing, to medication usage review, the pharmacist is the person who's unifying all of that from their unique expertise as healthcare professionals in medicine. So that brings us to the second part of the journey, which is, who is your pharmacist? First thing, and maybe very obvious but worth stating, is that pharmacy is a regulated healthcare profession. That is to say, you have to be eligible to register with the Pharmaceutical Society of Ireland, who, for the government, are the people who protect the public interest in the practice of pharmacy. So that's a regulator acting in your interest, formed from a council, the majority of which is lay, that regulates and oversees both the registration of pharmacists and uniquely also the premises from which they practice for healthcare professionals, pharmacy. So it's a very controlled, standardized environment that is set up to assure that the services that pharmacists are giving are safe for you. If you think about it, it has to be. Uniquely, pharmacists are the people who have monopoly, if you wish, on poisons. And so they have really got to be both knowledgeable and safe in their practice to protect the public interest. So how does the Pharmaceutical Society of Ireland do that? It does that through registration of pharmacists, through setting a code of ethics, referred to as a code of conduct for pharmacists, which sets ethical frameworks for them in terms of what is their decision making when things aren't black or white. It also has an inspectorate that inspects pharmacies and pharmacists to assure that they are met the standards that are set by the Pharmaceutical Society of Ireland. And for you as a member of the public, if the service that you receive from a pharmacy is not to your expectation, there is a complaints procedure for you, and behind that a pretty robust fitness to practice procedure which can result in a pharmacist having to leave the register because of the complaint that you entered. So they are a very regulated healthcare professional. The Pharmaceutical Society of Ireland is equivalent to the Irish Medical Council, the Nursing Board, the Irish Dental Council. It is the regulator acting in your interest on pharmacies. In terms of pharmacies themselves. And what I did here was I've actually taken a floor layout plan rather than kind of the esoteric perspective that I had to give you an idea of what a real pharmacy looks like. But I suppose a few things to say here. One, which you possibly all know, that since 2010, all pharmacies by law have to have consultation rooms. But two, I suppose, and the main point that I'm trying to make here is that there are over 1,800 pharmacies in Ireland and over 5,000 pharmacists. So it's the third biggest registered healthcare profession. But when you think of that network of pharmacies distributed all over Ireland, that makes them also the most accessible healthcare professional to you. What does accessible mean? Does accessible just mean that that's convenient for you in the sense that it's either within walking distance or public transport? It does, and that's important, but it means a lot more. It means that you can use, and the department and people involved in policy can use pharmacies very wisely to actually deliver services in the communities close to where people are living. And as you know, there's a very large shift to actually now deliver care more out of hospitals in your community where possible. So that's a very big enabler for pharmacy going forward, is that they're so accessible in both urban and rural and all over Ireland. Who becomes a pharmacist? We have a School of Pharmacy here in the College of Surgeons. You're going to meet fourth year pharmacy students later on. There's a School of Pharmacy in Trinity College Dublin, and there's a School of Pharmacy in University College Cork. In Ireland, it's 5 years of education and training to be eligible to apply to be registered as a pharmacist with the Pharmaceutical Society of Ireland. Students who are very academically bright from leaving certificate, so it's a very high demand course, come to RCSI, Trinity and Cork, and they spend 4 years reading for a primary degree either in science or pharmacy. Once they've got that degree at the end of their 4th year, they then come to the College of Surgeons for their 5th year, and we run for the Pharmaceutical Society of Ireland the National Pharmacy Internship Programme. That's effectively an internship where they are based either in a hospital or in a community pharmacy, and with the option of being placed in a non-clinical setting, such as pharmaceutical industry. And after they successfully complete that, they then get a Master's of Pharmacy from RCSI. If you have a Master's of Pharmacy from RCSI, then you can apply for registration as a pharmacist in Ireland. So that's the only route to become registered as a pharmacist for people who are studying within Ireland. What do we actually teach students? What we do is we spend a lot of time thinking about who is it that a pharmacist is, because you've got to know what your end is to design the process to take you there. And from our perspective, a pharmacist is at the center a caregiver, which I'm going to speak about presently, and their expertise is uniquely in medicines. So what do we teach them with respect of medicines? They do a variety of subjects that are unique to pharmacy schools and unique as healthcare professionals. They do pharmacology, which is how drugs work, clinical pharmacology, how drugs work with patients and prescribing science. They do a subject called pharmaceutics, which is really around drug delivery. I'll speak a little about that later on. They do a subject called pharmacognosy, which is really about natural sources of medicines. And they do prescribing science. So they do all of that to a high standard, and they do that more than any other healthcare professional. And I know, because I lecture in also to the School of Medicine. Nobody knows more about medicines than a pharmacist, period. And that's by virtue of the curriculum that is put together that they have to get through to get their Masters in Pharmacy. As well as that, and having all of that expert knowledge, they need a set of other skills. They need to be health advocates, and I'll talk about the role of pharmacists in public health. They need to be good communicators. There's no point having all of that information if you can't communicate well. This evening, those of you who are doing the brown bag review will see it's really going to be important how good the communication skills of the pharmacist is with you for how effective that review is. So they have to be good communicators. They have to be good collaborators, because nobody's now delivering healthcare in silos. It's all moving towards team delivery. So they have to be able to interact with physicians, with surgeons, with nurses, with allied health professionals. They have to be professional, have to understand what professionalism means, have to be a scholar. And what I'm really meaning there is they have to be able to do research, and particularly research that underpins their practice, so that their practice is evidence-based. Those of you who've been attending the MiniMed series will have had a really fantastic lecture by my colleague Dr. Anthony Cummins from Primary Care Centre, in which he talked a lot about evidence-based and how evidence-based influences his prescribing. So healthcare delivery is more and more about evidence-based, and evidence-based is generated by the ability to be a scholar. And also they have to be a manager. All healthcare professionals have to then manage a collective set of activities to be effective in their role. So that's what we do. They're on the register, they're accessible, they're regulated. Who's to say they're to maintain that competence? And that's a very big issue that I think we've all learnt about in the Irish healthcare system through unfortunate examples of registered healthcare professionals who have continued to practice even though they have not been competent. And so for pharmacists, that is set out by a new body which is referred to as the Irish Institute of Pharmacy. So that effectively is the leadership body for pharmacy in Ireland. I had the pleasure earlier this week at being at the inaugural address by their new executive director, Dr. Katrina Bradley. And it's actually based here in the College of Surgeons. So the Irish Institute of Pharmacy is leadership body. It's providing continuing professional development, which is mandatory, to ensure and assure that pharmacists remain competent. And remember, nothing changes really very much faster than drugs. So it's very easy to be out of date. I sometimes think when we graduate students, how long are they competent for? And it's possibly only 4 to 5 years, and they actually then have to do continuing professional development so that their practice remains up to date. So that's a role that's now gone to the Irish Institute of Pharmacy. It also has a leadership role, so you'll possibly hear a lot of it if there's national debate and dialogue about drugs, about pharmaceuticals. The Irish Institute of Pharmacy will be speaking from a professional perspective, not from a regulatory perspective, not from a financial perspective, but actually from a professional perspective of what is the best professional thing to do. Rather like Paddy Bro, whom you met earlier on as president of the college, leads the charge as the leader for surgery in Ireland. So if there's a debate on RTÉ television and there's a question about what way should surgical practice best be structured, Professor Bro is a person who would be an important voice in that debate in Ireland. So that's new, and that's really about assuring competence. So what does that mean as I draw this second part to a close? Really what it means in this rather maybe garish slide, but still trying to make the point that pharmacists are medicine information experts. As Dr. Bradley said in her inaugural address on Monday, when you think about medicines, you should think about pharmacists. Third part, pharmacist as caregiver. I've said a lot about medicines. I'd be interested, maybe just for a show of hands within the room, how many people within this room attending this lecture this evening are on regularly prescribed medicines? If you could raise your hands. Cool. Glad to see the students, not all of them around, right? So we're all depending, including most of the people in this room, on your good health for the benefits that medicines have brought. They have simply transformed healthcare delivery. It was interesting when Paddy Bro was presenting to Professor McGuigan, and Paddy is a general consultant surgeon at Beaumont Hospital. Even you think if in 1960s, if I had a peptic ulcer and I went to my GP, he would have sent me to Paddy Bro possibly for surgery. That never happens now except in very unusual circumstances. Since the 1970s with drugs like Tagamet and more recently with drugs like Losec, that can all be perfectly treated by medicines. There is no need for invasive surgery. Simply transformed medicine. And I know a lot of you will have heard about that the chemical and the small molecules that form drugs, that we've kind of hit, we're going off the bit of a cliff where there's not many new blockbuster drugs coming forth. And that's presenting a challenge to lots of the pharmaceutical companies that are in Ireland, the ones that had all the patents on drugs, like I'm sure some people in this room are on atorvastatin, branded as Lipitor, that those big blockbuster drugs and those big discoveries, there's not too many of them coming down the road. But if that is the case in this challenge for those small chemical molecules, there's a whole new world of medicines in parallel coming through biology, high-tech biological drugs, recombinant proteins, blood products, vaccines, stem cell therapy. Really privileged in the School of Pharmacy to be collaborators within the college on an 8.7 million European Union funded project called AmCare, where we're assisting in generating a device which will get stem cells to the heart of somebody who has had a myocardial infarction, a heart attack, where heart muscle has been damaged, so that these stem cells can regenerate that tissue in the heart to restore a normal heart function. Tremendously exciting. So medicine continues to grow. Those of you who, again, in this MiniMed series would have been at Dr. Giampiero Cavalleri's talk will also have heard about stratified medicine. And what's fascinating about stratified medicine in terms of the genetics of the person and personalizing the medicine to that person so that in the future we will have the right medicine for the right person at the right time. So all of that has really been made possible, I think, by the benefits that medicines have presented. And those benefits are cure of a disease. I'm always fascinated in my simple mind by penicillin. I get a streptococcal sore throat, I take penicillin, it's gone. It's fantastic. It just gets rid of it. Cure of a disease, slowing of a disease. There are new drugs for Alzheimer's disease. They're unfortunately not curative. The acetylcholinesterase inhibitors will, however, slow disease. And that's good because that improves quality of life, improves memory, improves cognitive function, and so on. It's not ideal. We would wish it to be cure, and there's a lot of work to do that. But having a medicine now that slows that disease is really important. Preventing a disease or symptoms. You can think of vaccines that prevent disease, and I'll talk a little bit about that later on. And reduction of symptoms. I have a cold since Sunday. I'm taking paracetamol as I speak. It's reducing my temperature. It's cool. That's reduction of symptoms. For all of that, there's no magic bullet. Paul Ehrlich, a great scientist and physician, invented that concept of the magic bullet. The idea that there's a bullet that comes, that very selectively gets the disease or the symptoms, cures it, and no side effects. And in a sense, that's kind of the goal and remains the goal and the holy grail of drug discovery and of education of pharmacists and physicians. But it's not there. We've never got it. And so on the flip side of this equation, for you as consumers of medicine, there are risks. The risks: inappropriate prescribing and delivery. What do I mean by inappropriate prescribing? Wrong drug, wrong dose, wrong dosage form. What does that mean, wrong dosage form? That's a really particular pharmacist thing. Before Christmas, a colleague of mine who's a pharmacist in Stillorgan, a patient of his, a lady who has angina, and angina, as you know, leads to terrible pain of the heart due to lack of blood to muscle, was actually going into hospital more to have her angina treated. She was taking, and lots of you may remember this drug, glycerol trinitrate, which is a nitrate drug that you put under your tongue. It dissolves and it relieves the pain of angina, but that wasn't working as effectively. And so the pharmacist looked at the other medicine that she was taking. She had recently, by her GP, been prescribed amitriptyline, which is generally used for depression, but also can be used for certain types of pain. And she had a certain type of pain for which amitriptyline was appropriate. But amitriptyline causes a dry mouth as a side effect. So she was taking the amitriptyline, her mouth was dry, the glycerol trinitrate wasn't dissolving under her tongue, wasn't treating her angina, she was having to be hospitalized more. The very simple solution was actually to change the dosage formulation. Rather than giving the glycerol trinitrate as a tablet to dissolve under the tongue, to give it as a spray where it was already dissolved, and everything was back to normal. So a very simple change of dosage form makes a huge difference for this lady and indeed for the healthcare system. Inappropriate delivery is where patients don't necessarily receive medicines. There's concern with introduction of prescription charges under the General Medical Service Scheme. Some patients can't afford their medicines anymore, so we're seeing medicines poverty again. So they're not being able to get medicines that they do need and should have, and that brings its own risks. Poor adherence. I'm going to talk a little bit subsequently about poor adherence and why I think that's important. And inappropriate monitoring. So not monitoring properly the reason that you gave the medicine. You gave the medicine because, and I'm sure there are people in the room who have blood pressure, hypertension, who are taking antihypertensives. Of course, to know that the dose is right and continues to be right, you have to measure and monitor your blood pressure. So the two go together. If you don't have the monitoring, if you have inappropriate monitoring, then that brings new risks with respect to the medicine. So the challenge is to balance between the undoubted benefits on the left-hand side and generally the risks on the right-hand side. And pharmacists are uniquely placed to do that, and they do it principally through 4 areas. 1, optimizing the use of medicines, so making sure that medicines are used as best as possible for you. 2, supporting people to live healthier lives, so that idea that I talked about earlier of advocacy and public health. 3, supporting people to self-care, so that people can safely get medicines themselves through their pharmacy and can look after and be empowered to look after their own health. And that's a big issue in the European Union, as the Commission wants to make more European citizens more knowledgeable and take more ownership of their own care and health, and use the pharmacist to do that. And supporting people to live independently, and especially for patients with chronic disease, for those with diabetes mellitus, for those with Parkinson's disease, lots of chronic conditions that are at present really treated in a kind of a hospital-centric model in Ireland, which is very expensive and not convenient for patients, to actually begin to provide that care closer to those people's homes. And that's back to that accessibility and network of pharmacies that we talked about earlier on. So there are 4 areas that I briefly want to explore with you with respect of how a pharmacist can benefit you and your family. So let's start with the idea of optimizing medicines. And I suppose this is really key to what we're doing tonight when we have the brown bag review. So the idea of a pharmacist being involved in a review of the medicines that you have been prescribed or are taking. There are 3 forms that can take. It can be a prescription review. It can be, as some of you are going to have this evening, a brown bag review, a medicines use review type 1. Or top of it, it can be a clinical review where the pharmacist also is with you and also has access to your notes, your diagnosis, your blood tests, and all of the issues involved in monitoring that I previously talked about. So starting with prescription review. Prescription review is really what most pharmacists do when you present a prescription. You might often wonder, where are they gone with that prescription and why is it taking so long? What is going on? And the reason that something is going on and is taking long is that they also have a legal responsibility to ensure that you get the right medicine. That's not just the responsibility of your prescribing doctor or dentist. That's also their responsibility. So they're checking that the prescription is lawful. That sounds really odd. Lots of prescriptions in Ireland aren't lawful. There's a lot of benzodiazepines on the street. They're generated by false prescriptions. Benzodiazepines with alcohol account for more deaths in Ireland per year, 3 times the deaths that occur on our road. So whilst Gabe Byrne and the Road Safety Authority are doing a great job, there's a big issue going on that's not getting a whole lot of airtime. Benzodiazepines and alcohol. Huge cause, over 3,000 deaths in Ireland last year through misadventure of that combination. And it was a surprise to me, I have to say, as a pharmacist, that there were so many even fraudulent prescriptions. And there were times in that aesthetic space that you saw that I would accept a prescription, tell the patient to come back, it was a fraudulent prescription, and there was a Garda from Pearse Street to take them away when they came back to collect the prescription. So fraudulent prescriptions exist, and that's one thing a pharmacist is doing in prescription review. They're also looking at the drug, the dose, the duration, the interval, and seeing all of those things are appropriate. Medication usage review is actually where the pharmacist is meeting the patient, sitting down in the consultation room that we talked of previously, and actually determining and increasing the knowledge of the patient around their medicines so that the person who's prescribed those medicines can get the most out of them, can know about side effects, can reduce the incidence of adverse drug reactions, and actually improve the way that they take those medicines, which is adherence, which I'm going to talk about in the next slide. And clinical review is the top. Tends to happen more in hospital pharmacy at present, where hospital pharmacists have access to all of your notes and blood tests and so on. But also is happening in community pharmacies in other jurisdictions where through an electronic infrastructure, all of your notes can be available to the healthcare professionals who are looking after you. You give their permission, they're online, your pharmacist can check them so that there's less likelihood of a mistake. And I'll talk about that with respect to how that's developed in Scotland. So adherence, I've said twice already I was going to come back to adherence. What is adherence? Sometimes referred to as compliance, sometimes referred to as concordance, but all the same thing. Basically, do you take your medicine as prescribed? There's been no really large-scale study, to my knowledge, in Ireland on that. But internationally, and from a recent study in Aston University, a colleague of mine, Professor Christopher Langley, did a very large study called the Aston Medication Adherence Study. We know that 30 to 50% of people with chronic disease don't take their medicine as prescribed. So that's a pretty large figure. But is that significant? What does that mean? It's pretty significant, as you can see from some of the facts that I've just put on that slide. So a significant disadvantage to the quality of the health of people, the poor adherence to prescribed medication. But adherence and taking medication as prescribed and to understand it is actually difficult. And in fact, a lot of the information that we have comes not from the hard sciences or the natural sciences or the pharmaceutical sciences, but really from people who study behavior, the behavioral sciences and the social sciences. Dr. Frank Doyle, who's a psychologist, recently at a roundtable symposium for EPOSI, and I'm not sure if there's anyone here a member of EPOSI. EPOSI is a platform for Irish patients and organisations in science and industry. And he's really saying that it's multidimensional and complex, and it's got to do with emotional and environmental reasons. But basically there are two reasons people don't take medicines. One, it's inadvertent. They don't follow the instructions. They're really complicated. They were never explained, so they don't take them correctly. Or two, it is advertently. And lots of folk are worried about side effects, about adverse drug reactions, about becoming addicted to medicines, about thinking actually a holiday from this medicine is possibly going to do me good. So lots of reasons why people, whilst understanding the benefits of medicines, are reluctant and sometimes just don't take them correctly. And that has, as I said, a significant effect not only for the quality of their care, but as you can imagine, for a healthcare provider like the Health Service Executive, a significant issue in terms of wastage. One of the things I also became used to as a pharmacist in Dublin City Centre was, unfortunately, when a patient died and relatives would come to me and say, "Can I bring you back, Paul, the medicines that they used?" I said, "That's fine." And sometimes you would just get carrier bags and carrier bags and carrier bags of medicines coming back. Years and years and years of prescriptions never taken. This is bizarre. Thousands of pounds and euro gone somewhere. And I'm sure people here have seen that, just the amount of medicines that are sometimes stacked and not used because of people's fear around medicines. So one of the real advantages of that brown bag review is actually by improving your knowledge of medicines, it improves your ability and your confidence in taking those medicines so that you avoid some of the quality issues that I've put here. In terms of the kind of questions that brown bag reviews sometimes throw up, you can see they're kind of related to the things I've talked about. How can I tell if it's working? What is the minimum effective dose? And so on. So I hope that's going to be really beneficial for those of you who are participating this evening, and for those of you who aren't, medication usage review is something your family pharmacist can do for you locally. In terms of the second area, which is in public health, where pharmacists become involved so that people can avoid sometimes taking medicines. Our sister college down the road in Kildare Street, Royal College of Physicians of Ireland, has this week spent a lot of time thinking about 10 years since the smoking ban, has announced that wants Ireland to be smoke-free by 2025. That's less than 5% of the population smoking. That's going to be a difficult target to meet. Pharmacists have a key role to play in this, and from this paper here, it actually shows that you double the chances of giving up smoking if you avoid of counselling services from your pharmacist. In terms of supporting people to self-care, recently in Ireland you're aware that emergency contraception can now be available through pharmacies. It used to be that that was prescription. You can now get your seasonal flu vaccine through pharmacies. That used to be available through prescription. So giving back to people more power and more decision about decisions for their health in their own community. And there was a lot of concentration, I think, in Ireland for a period of time on the risks associated with that, but now there's more balanced decision making and more drugs becoming available to you that you can take without prescription, but under the supervision of your pharmacy because of the benefits that are on this slide here. Improved access, improved clinical outcomes, improved public health, especially for seasonal influenza vaccination. Not enough people get it, so you're trying to build up immunity in the population so that more people who have vaccinated, that is much better public health and less chance of all of us getting influenza. And there's economic benefits in that is not resulting in hospitalisation and GP costs and so forth. Finally, I want to talk about chronic disease and this notion of Ireland being very centred in chronic disease, being through hospitals, and trying to move that into primary care settings and pharmacists having a key role in that. It's a really good paper published in the current issue of the British Medical Journal, and this is for patients who are Parkinsonian in the Netherlands, and this study started in 2004. And those Parkinsonian patients found that there was a lot of emphasis from their general practitioners on medication and reducing the motor symptom side effects, and a lot of concentration sometimes on stereoselective surgery from surgeons, but not much other assistance. So what the Netherlands did, and the Netherlands also has a unified health insurance system, was that it brought together a whole heap of healthcare professionals, as on this slide, that were all available to those patients with Parkinson's disease, and patients could self-refer themselves to the healthcare professionals that are on this slide. The medication notes and the histories were all available centrally on an electronic patient record that all those healthcare professionals could access. That study has just concluded, and not only has it improved the quality of care for those Parkinsonian patients, not only has it allowed them to stay at home and empower them, but it has also reduced the cost to the Dutch healthcare service. So this is a hugely powerful model of a new way to treat chronic conditions in which you as the patient are at the heart of it. And actually all of the relevant people are serving you. And that improves, as I say, an increased quality of care, reduced cost, and the pharmacist had a key role to play in that in the Netherlands. So finally, it gets me on to the last part, which is, what is the future like? Future is always difficult to predict, possibly really difficult to predict in Ireland right now, because we know that we're moving to a unified health insurance model in which the money follows you, the patient, a little bit like the Netherlands. You get the service delivery model at present and turn it upside down and put the patient back in charge and look for increased value for money. In truth, up to now, and certainly with respect of pharmacy, Ireland has not really been distinguished in its planning, which is kind of unusual if you think that there's over 2 billion spent every year on pharmaceuticals, why so much planning was absent in thinking about what is the best way for Ireland to utilise pharmaceuticals. So really lack of policy direction, which really sits with the Department of Health. And then when they did wake up in 2008, the money had dried out and it's all been about cutbacks and so on. Other countries have, I suppose, been more inspired, countries that plan better and have a better history of planning. The United Kingdom, in particular Scotland. I don't think Scotland is a good exemplar. There's not a similar population, similar disease states across the two. New Zealand, United States, Canada, and so forth. And they've very much increased the role of the pharmacist in all of the areas that we've talked about, in terms of self-care, in terms of chronic disease management, and enabled all of that by establishing this electronic patient record that connects all of these healthcare professionals. Scotland has done that and is now moving on where it's saying, actually, the GPs and the medics are the diagnosticians. All pharmacists are going to be independent prescribers in Scotland by 2023, and they're the people with whom caseloads are going to be shared, and they're going to make the decisions around what medicines you get and their monitoring. And they're just across the water. So really moving really far ahead, and I think going to influence practice here. What can we say in the absence of a white paper about a unified health insurance model? What we can say is that it's going to have an emphasis on quality. It's going to have an emphasis on regulation and patient safety. It's going to be, we hear a lot about money following the patient, about having the intervention at the least complex point, close to your home, and increased value for money. And when you think about all that I've said so far about how pharmacy brings that to you as patients, it's not difficult to imagine that actually the future is very bright for pharmacy, and that within a unified health insurance system, they're going to have a very large role. In conclusion this evening, what I've talked about is the changing of role of pharmacist from apothecary through to caregiver. Who are pharmacists? They're highly regulated healthcare professionals. They're well educated. Their competence has to be maintained. They are accessible to you and your family. They're really important because they are the people who can reduce the risks in the balance of benefits and risks for medicines, and most people in this room are taking prescribed medicines. They have an increasing scope of practice in other jurisdictions. As we move towards a unified health insurance model, there's a lot of the service delivery that pharmacists can give that will make them intrinsic to healthcare delivery going forward in Ireland. It's been a great pleasure talking to you this evening. Thank you for your attention. There are three take-home messages from this evening. One, I'd like the attendees to have greater knowledge about who a pharmacist is and the services they can provide. Two, I'd like them to be more assured in those services and to avail of medication usage reviews in the future. And three, I'd like them to imagine the role of a pharmacist in a new unified health insurance system.
Well, I find Professor Gallagher's talk very interesting, especially where he's talked about how much the role of the pharmacist in caring for their patient has developed, where he gave a lot of key areas about how they had to be the educator, the communicator. I thought how it's become more patient-centred was, I think for a person from the general public, I find that very encouraging and very reassuring.
The description of what a pharmacist is, I thought it was very good, and that I could associate with what he was saying with my own pharmacist in Terranure. I'm looking forward to the next series of MiniMeds.